Okay, guys, welcome to part 5 of your pharmacology lecture. We're going to talk about 3 other drugs that are in your scope. We're going to start off with albuterol. Albuterol is definitely a drug that you guys are going to become pretty familiar with pretty quick in this class and out in the streets. The class of drug is known as a sympathomimetic or a beta 2 selective adrenergic bronchodilator. I'll accept either one of those answers. Sympathomimetic means that it's going to mimic the sympathetic nervous system. We're going to talk about that a little bit in your anatomy and physiology lecture. Basically, this is your flight or fight response that the body has. So what I want you guys to think about is, let's say I get you guys butt naked. I strap a whole bunch of raw T-bones in you, and I throw you into a 6x6 cell with a Bengal tiger, right? That's going to stimulate your sympathetic nervous system. It's going to increase your heart rate. It's going to increase your respiratory rate. It can bring up your blood pressure. You guys can get sweaty. You guys can become pale. Your eyes are going to dilate because you guys are going to be really trying to find an exit real quick. When I talk about beta 2 selective adrenergic bronchodilator, beta 2 is the receptor site where this drug is going to attach to. In your body, you have alpha receptor sites, which are basically head to toe. You have beta 1 receptor sites, which are found in the heart. You have one heart, beta 1. Beta 2 receptor sites are found in the lungs. You have 2 lungs, so that's where your beta 2 receptor sites are. So this is a drug that's going to work on the lungs. This is used for any kind of reversible airway obstruction caused by any type of respiratory illness with wheezes associated in the lungs, okay? So anybody that has wheezing in their lungs, and we're going to talk about that more in lab, you guys will be giving albuterol to. There are some caveats to that, but we'll get there when we actually get into lab. Contraindications for this drug. Yes, some people are hypersensitive to this drug. I've never seen this in my years as EMS. I've read about this in some case studies that are found online, but I've never actually seen it. There are multiple drug interactions with this. Beta adrenergic agents. Adrenergic, I want you guys to kind of think of it or associate it with the sympathetic nervous system. Think of it as adrenaline, right? So if I have a beta adrenergic agent, it's something that's going to stimulate my sympathetic nervous system, and I give another stimulant on top of that stimulant, it could potentiate the effects of the albuterol, which means it can really make the albuterol work a little bit more, but we're going to have some side effects with increase in heart rates, increase in respiratory rates, so on and so forth. MAO inhibitors, they're not used too much anymore in medicine. They were pretty popular drug back in the day that they used for some kind of like psych disorders like depression or bipolar or something like that. If we do give albuterol with the MAOI inhibitor, it's going to produce a hypertensive crisis, and that means that we're going to really jack this patient's blood pressure up through the roof. Beta adrenergic blockers, there's a lot of people that are just called beta blockers. Beta blockers are used for people that have some kind of cardiac conditions that might have for whatever reason, a faster heart rate than a doctor might want, or somebody that has high blood pressure, they could be on a beta blocker in order to try to slow the heart rate down in order to keep the blood pressure down, okay? So if I have something that's blocking that receptor and I'm giving a medication such as albuterol that's supposed to stimulate that receptor, but that receptor is already blocked, it can decrease the effectiveness on how fast that albuterol actually works, okay? The administration for this we do give through a nebulizer setup. We're going to talk about that more in lab. Your adult dose is 2.5 to 5.0 milligrams up to a max of 10 milligrams. Usually given over 5 to 15 minutes. We will recess our patients, and then we can repeat if necessary, okay? But your max dose is 10 milligrams. Pediatric dose for albuterol is basically the adult dose cut in half. 1.25 to 2.5 milligrams with a max of 5 milligrams. Given over 5 to 15 minutes may be repeated if necessary. Side effects do show up more and more the more drug that you guys give. I'm going to teach you guys in this class specifically for asthmatic patients or anybody with wheezing to be pretty aggressive in this treatment. So really I'm going to be training you guys to go straight to 5.0 milligrams right off the bat. What this drug does is you guys have bronchis. Bronchis are the basically what branches off the trachea that leads into the lungs. And they're just these, pretty decent sized hoses, basically, is what it is. And when somebody's having an asthma attack, the actual bronchis start to get irritated. Something has irritated the lung tissue. It could be an outside source. It could be pet dander. It could be dust, smoke, stuff like that. But either way, the bronchis are becoming inflamed. When we give this to our patient, they start breathing this in. This cuts back the inflammation that's going on in the bronchis and helps to dilate the bronchis open so that patient can take that nice deep breath in order to get good, adequate gas exchange into the lungs to hopefully resolve their shortness of breath. We will be talking about albuterol a lot more once we get into our respiratory emergencies. Okay, next drug is atropine. Atropine is an interesting drug. It's not used too often, specifically at the EMT basic level. In fact, you guys might go your whole careers and not see this drug, but it is in your scope, and it is in your scope for good reason. Really, this is a drug that is associated with another drug known as pralidoxime, and I'm going to talk about pralidoxime later on in a different lecture. But atropine is basically used, that you guys will be using basically on yourselves if we do have some kind of local terrorist attack or possibly some kind of nerve agent exposure, okay? The class of drug is known as an anticholinergic or a parasympatholytic. It's used for suspected anticholinesterase poisonings. Anticholinesterase poisonings are also known as organophosphates, which could be like pesticides or possibly even some fertilizers. Specific types of mushrooms, wild mushrooms that grow in the wild, and any kind of nerve gas, so any kind of nerve agents like a sarin gas, a VX gas, something like that. There are no contraindications when indicated. Your adult dose is 2.0 milligrams through an auto-injector, and that auto-injector also does have pralidoxime as well. So really, it used to be called the Mark 1 antidote kit, and the Mark 1 antidote kit had two pre-filled syringes. One was atropine, one was pralidoxime. So you'd have to give yourself two different shots. You'd give the atropine first, and then the pralidoxime, and then enter into the hot zone, or enter into the area that had nerve agent exposure to it. You'd get about 30 minutes of good outcomes, and then you'd have to leave that hot zone, redose again in order to go back in. Any of you guys that were in the military, you might have already experienced this or definitely got some training on this. But we really give the atropine first and then the pralidoxime. Right now, it's also known as the duodote. The Mark 1 antidote kit is now known as the duodote. The duodote is technically one syringe, and it's a time-release auto-injector that will give you the atropine first and then the pralidoxime in order for you guys to get out there and get into the hot zone in order to help patients out. That's really all I'm going to say about atropine. All the information that you guys need for the exam is on this slide. Just remember that we are giving atropine first and then the pralidoxime. Again, I'll talk about pralidoxime in a different lecture during this recorded lecture series on pharmacology. Okay, the next drug I'm going to talk about is epinephrine, and the concentration of epinephrine is 1 to 1,000. As you guys move up in level of licensures, you guys are going to be able to play with different concentrations of epinephrine in order to help patients. But epinephrine 1 to 1,000, this is basically top shelf stuff. This is a very dangerous medication. Basically, this is a shot of adrenaline. It is one of the purest forms of adrenaline that we can give to our patients. The class of drug is a sympathomimetic again, so it mimics the sympathetic nervous system, right? We're going to kickstart the adrenal glands in the patient's body by giving them the epinephrine, and they're going to have a serious dump of adrenaline, okay? So the side effects of this would be their heart rate's going to go up, their respiratory rate's going to go up, their blood pressure is going to go up, they could become sweaty, they could become pale, all kinds of different stuff can happen to them. Why are we giving this? We're giving this for severe asthma attacks, or what we call severe bronchospasms. or anybody that is in anaphylaxis. Okay, anaphylaxis is a very severe systemic allergic reaction. We're going to talk a lot more about epinephrine once we get into our respiratory chapter. Contraindications, there are none. You cannot be allergic to adrenaline. It is produced naturally in your body, and that's basically what this is just a shot of adrenaline. Drug interactions, just like with albuterol, if I'm giving a stimulant, right, which epinephrine is, and I already have something blocking my receptors, right, it can decrease the effects of the actual drug. It could take longer for this drug to kick in, all right? Administration for adults is 0.3 milligrams, 1 to 1,000. Sub-Q or IM, we usually give it IM or in a pre-filled auto-injector syringe or what's called a self-limiting device, okay? You guys, again, this is a very dangerous drug. This is a very hard-hitting drug. It's an honor for you guys in the state of New Mexico to be able to give this drug at the basic level. And we provide you guys with certain syringes with this drug so that you can only pull up a maximum amount of epinephrine of 0.3 milligrams. There's no way you guys can do any more than the 0.3 by pulling it up in the syringe. Pediatric dose is 0.01 milligrams per kilogram. We usually give the pediatric dose as subcutaneous. It's a little bit hard hitting through an IM injection for our pediatric patients, so we'll give it through a sub-Q, and we can reach a max dose of the adult dose of 0.3 milligrams per dose, okay? Yes, you can redose this, all right? There is not technically not a max. We're going to talk about that a little bit more when we get into our respiratory illnesses. The big thing with this drug is you guys have to administer this drug under online medical control or through the medical control emergency physician. This is the doctor that you guys are going to be calling at the receiving facility where the patient is going to be transported to ask permission to give this drug. Again, there's some caveats to this. We're going to talk a little bit more about that when we get into respiratory, but for now, you guys need to contact an MCEP, also known as online medical control, before you guys give this medication, all right? This drug is going to increase everything. So if this patient is by chance having a heart attack with an asthma attack, we can make that heart attack worse, right? We need to use caution with those patients, specifically our older population, and given epinephrine. But again, we're going to play that game of what's going to kill that patient first, and what's going to kill that patient first is because they can't breathe, not necessarily the heart attack. We're going to talk about that more in both respiratory and cardiac lectures, all right? And then there are some wheezing out there. I'm not going to hit this too hard right now, but be aware that not all wheezes are due to shortness of breath. There are some wheezes out there that are due to cardiac symptoms, and we will talk about that when we get into our cardiac lecture. I'm going to stop the recording for here for just three drugs, and I'll see you guys on the next recording. Thanks.